the B scan and prior experience. So these helped in this case. Then coming to little more challenging cases, case number 2, 65-year-old female, history of injury with a bottle. Actually, the patient's grandson hit with accidentally with a bottle, and the PCIL was cataract surgery was done 5 years ago. Patient presents with PL positive and PR accurate vision. You can see over here, there is the pseudophacocyl. Superiorly, the PCIL is subconjunctival space with the uveal tissue prolapse. And you can see B scan, it is relatively normal. So patient underwent wound exploration, IOL explantation, iris abscission and wound repair at the first stage. Then second stage, PPV plus SFIL, patient is doing better, BCVA is 6/12. So what is the learning from this case? Learning number 2, anatomical confirmation we saw the B scan is normal, there is no RD and all, and prior experience. We have operated similar kind of cases in our fellowship time. To be specific, there was a case which our fellow Anubhav presented during our, when I was a MO in Arvind Hospital Madurai, similar kind of case. We operated, and based on that experience, I managed this case in my practical life. Coming to case number 3, a little more challenging case, 55-year-old lady, history of phaco surgery previous day, next day surgeon has sent to you. So intraoperatively there is sudden upthrust on table that the surgeon is telling you, IOL surgeon, she sutured the wound and the surgery was abandoned, referred to the VR surgeon. So the diagnosis over here is definitely kissing choroidals is there and expulsive choroidal hemorrhage. So here comes our publication related experience. So we have recently published in JCRS, which is probably the largest series, 52 cases of expulsive choroidal hemorrhage. Here we had the experience that if we wait for maybe 2 weeks or 3 weeks, these kind of hemorrhage usually resolve on its own. Resolve means let's see. So this case was observed only. Observed means conservative management with steroids, systemic and topical. We can see the expulsive choroidal hemorrhage, suprachoroidal hemorrhage is resolved, very drastically resolved. However, there is retinal detachment because one portion of the retina was there in the wound actually. In a hurry, that portion of retina was also taken in the suture. So I took this patient with a 42 band, past my vitrectomy, trichotwas, and I took the help of PFCL use and silicone oil injection. And this is post SOR, patient is having 6/60 vision. So these were eyes where the surgeon will be, antecedent surgeon, they need your help, and these are very dangerous things. However, with the here what comes, the research activity related to the case that you are operating and also your prior experience. Coming to case number 4, this was a 25-year-old male, history of cricket ball injury during COVID time, that was 2 years ago, patient presents with hand movement. So the diagnosis is obvious, chronic RRD with CD with full thickness macular hole is there. So here also 42 band with past one vitrectomy with PFCL and SOI was done, and the patient is doing fairly good. So what is the learning number over here, learning point over here? You have to use the surgical adjuvants like a 42 band and PFCL as I have used over here, and explain the GBP to this patient. This patient was very much willing. So despite the GBP, he told sir no problem, you carry on with the surgery. And also your prior experience helps in these cases. Coming to another scenario, 50-year-old female, SICH with PCIL was done 10 days ago. Presenting vision is hand movement. The antecedent surgeon has sent to you. Here there is hypopion, we can see over here, hypopion is there, and there is thick fibrous membrane. However, in the posterior segment, we can see moderately dot vitreous echoes are there. So it's a diagnosis is endophthalmitis. They have managed medically, they could not do, so that's why they have referred to you. So what I did, AC was membrane removal, core vitrectomy and intravitreal antibiotics, and believe me, vision was 6/9 post of day 15. So the learning point number 5 over here is pre-op investigation supportive of anatomical integrity. Retina is on, moderate vitritis is there. Support to our IOL colleagues because they need the help at that time. So you need to be bold. You also should not be kind of frightened like them at that time. And prior experience, of course. So friends, these were the 5 scenarios when to be bold. Now coming to the other world where you have to withhold actually. So this is the case number 6, 21-year-old male, type 1 diabetes, 17-year history, and diagnosed with PDR. We can see over here straightforward diagnosis, proliferative diabetic retinopathy, and he undergoes PRP both eyes. However, at 3 months he presented with an aggressive look like over here, hemorrhage and whatnot. So whether you will go for surgery over here or not. So we went ahead with the lab, and you can see leukocytosis is there, and the patient was ultimately diagnosed to be CML. In the chronic phase, there were blasts in the bone marrow biopsy. So here this case is also published in a recently PubMed indexed journal. So what is the learning number over here? If the patient is systemically unstable, that means some associated other disease is there, or say HbA1c is very high, hemoglobin is low, hyperlipidemia, hypertension. In these cases, better to withhold. Don't go for a kind of surgery in this case. So here your prior experience also helps, and evidence-based medicine like the research that we told. Coming to case scenario number 7, this is not a single case. I am saying you some multiple cases. You can see chronic RD over here, chronic tractional retinal detachment, and in the right panel you can see there is intraretinal cyst, and here it is a closed funnel RD. So these are the kind of signs of chronicity where these are complex cases and patient presenting is delayed to you. So what is the learning presentation over here? Delayed presentation means the patient had less priority for this eye due to different reasons, financial or whatever. So post-op anatomical success will not simulate the visual outcome. So better to withhold in these cases. So coming to case scenario number 8. See the left panel, macula is on, vision is 612. You incidentally detect there is a TRD. Better to observe in these cases. Panel right, you can see there is a CTR drop, but patient is not having any complaint. I accidentally detected this. Do not post these cases for surgery. They should rather ask for the surgery. So learning number is anatomical attached macula. The patient should ask for the surgery. Case scenario number 9, you can see over here, there is kind of exudative RD kind of picture is there. And here you can see it is a sympathetic ophthalmia kind of picture. So left panel is exudative RD with CSR, right panel is sympathetic ophthalmia. So we have to differentiate between medical and surgical cases. Do not jump to surgery in all cases. Case scenario number 10, this is a kind of patient is moving to different doctors, and the vessels are almost thin and slender and sclerosed. So these patients having high expectation, better to withhold in these cases. So patients with high expectation and the poor functional outcome is expected in these cases. To summarize, when we need to be bold, relatively simple cases, pre-op investigation suggestive of retina is on, and you have evidence-based medicine based on your research, and you have useful role of surgical adjuvants like PFCL and a buccal, and the patient should understand the guarded visual prognosis. You need to support to the colleagues and your prior experience, very, very important. And when to withhold? When the patient is systemically unstable and you have evidence-based medicine supportive of this kind of condition will land you in trouble or say guarded prognosis. Retinal layers are disintegrated, high expectation from the patients, and the patient has no complaint, you accidentally detect. Don't jump for surgery. Medical and surgical retina you need to differentiate, and prior experience. If you can see over here, I have highlighted the prior experience because this is the number one thing that decides when you need to be bold and when you need to withhold. Thank you very much.
Thank you, Dr. Chitaranjan. This was an excellent talk with all his experience. He's a very experienced surgeon practicing in Odisha, and